in any way like I'm supporting, um, the horrors that are happening in Israel, you're doing me a favor. And just know you've all been in my thoughts and in our prayers. So I hope you find something. I'm pretty interactive. While I have a slide set and I will share my screen, I also really far prefer to be interactive. And I think in a topic like this, it's really helpful to get a lot of feedback. So be prepared to participate. And McLean, so we're like neighbors. Next time we'll do it together. Um, so I'm Julie Goldstein Grumet. I've been in suicide prevention a very long time, and I think a lot of what I'm going to go over tonight, you'll tell me how basic and how advanced, right? I have a set of slides, and we can kind of go along the way. What's most helpful, and take some questions. And honestly, I imagine you all. I have no doubt in my mind you come with your tremendous own depths of expertise, which means that you have your own experience and answers for one another too. But I am going to start. Let me share my screen. Tell me, do you see pyramid?
Mm-hmm.
Okay. So I didn't find stats in Israel, but I think there's probably some commonality. So just to begin with, what the looks like here in the U.S. and just to kind of lay the groundwork. Here in the U.S., it's about 48,000 suicide deaths most recently. Of those who attempt suicide, it's about 1.7 million adults and about 890,000 youth making attempts, and about 12.3 million adults and 3.3 million youth thinking about suicide. And I think the real takeaway here is two things. One, the vast majority people who think about suicide do not go on to make suicide attempts or die by suicide. However, many people have serious thoughts of suicide. And I think, a lot of the work I do is in prevention. I appreciate that tonight we're really on the deep end of clinical and intervention, but a lot of the work I do also is in prevention. And I think when we think about suicide prevention, we do want to think about it not just as what happens when people are in acute crisis, but how do we work further upstream to hopefully never have people get into that level of crisis. The other thing I think, and this is something we will certainly talk about, is that, as I said, majority of people who make one suicide attempt do not go on to die by suicide. There's a famous movie called Jumpers here in the US. It's about people who jumped off the Golden Gate Bridge, and very few survive. But of those who survive, I think 10% went on afterwards to kill themselves via suicide. Most of them said in the moment their foot left the safety and they stepped over, they immediately, and it's about 4-second drop, they said immediately during that drop, they said, everything I thought that I couldn't change, I could change. And some people actually did things to turn their bodies, twist, do things so that they actually would try to survive. So, I think it can be hard. I think in the US, again, one of the things we do a lot with, and there's been a huge emergence in the last 5 years, is the idea of lived experience or lived expertise. And we used to do, and we still do, things called psychological autopsies, right? So root cause analysis, what happens after somebody dies, and trying to interview their loved ones and get a better understanding of what led to it. But I think, and as that's very, very important. But actually, many people who made suicide attempts and survived them said, we're here, interview us. We have our expertise. Ask us. We will tell you whatever you want to know. And so in the US, there's been this tremendous movement about really incorporating people with lived experience, lived expertise, to talk about what is it that helped them, what didn't help. And even some of the things I'm going to go over momentarily are things that we've learned. So just to think about background, high-income countries very frequently have links between suicide and mental disorders. However, some data shows that about half the people at the time of their suicide death have no diagnosed mental illness at the time of their death, meaning it's very impulsive. And it's not always linked to something like depression or anxiety or an eating disorder or substance misuse. Those are known links as well, but it is not, we can't always assume that we could treat somebody's substance misuse or eating disorder or depression, and therefore the suicidal thoughts will go away. Nor can we assume that everybody who's having thoughts of suicide will cross the desk of somebody with a mental health professional, or will have a mental health underlying issue. So some of these things happen impulsively. Just that pervasive sense of hopelessness, truly cannot see in the future, a breakdown in the ability to deal with life stresses. It could be financial problems, it could be relationship breakup, chronic pain, illness. I know, given what's going on in Israel, a few people have asked me, might that lead to an increase in suicides? Clearly it's in many ways very unprecedented what's happening in Israel, and I don't want to speak to something that really isn't my expertise. But what I do know is actually after 9/11, and even during COVID, there were fewer cases, fewer people died by suicide for a brief period of time, because there's that. And certainly, that's what we see like happening in Israel, like that collective, not just collective trauma, but that sense of collective community support, rallying, in it to work together. And so it seems that sometimes thoughts of suicide get kind of put to the side for a brief period of time, while there's this intense feeling of, you know, supporting your neighbor, powering through. Obviously, I think it would stand to reason that the longer this goes on, the more who are lost and the more exposure to the more horror and more trauma and violence, it would stand to reason you could expect thoughts of suicide to increase. We know that experiencing conflict, disaster, violence, interpersonal violence, exposure to violence, abuse, loss, a sense of isolation are all strongly associated with suicidal behavior. So I think in particular, I think kids are highly resilient, but again, kids and their loss of their families, the loss just even of their day-to-day routine, I think all of those things are paramount to try to start talking about now and mitigate now. We also know that there are vulnerable groups who might be at higher risk for suicide: refugees and migrants, indigenous peoples, LGBTQ, prisoners. So these are things also to think about. And then the strongest risk factor for suicide is having made a previous suicide attempt. So and we're going to talk momentarily a little bit about how do you ask somebody about suicide, and certainly having made a previous suicide attempt, it kind of erases that ambivalence of most people, we're built to survive. And so the idea of getting over that hurdle of I actually would hurt myself, I actually would make a suicide attempt. Once you've made that decision to get over that hurdle and make that decision once, it is easier to make that decision again in the future, because that incredible stigma and ambivalence that you may have faced in your own mind has decreased. I think we do a lot, and I'm thinking about how do we just even talk about suicide, and culture really matters. I know you have your crisis line is available for an array of callers, and I think thinking then about what are the cultural values people place on suicide, what are the rituals, what are the roles, how do you ask people about what role suicide plays in their culture? Once upon a time, in my understanding anyway, once upon a time, if you died by suicide, you couldn't be buried in a Jewish cemetery. But I have a friend who goes to my shul whose brother killed himself, and the idea was during the moment that he killed himself, during that moment when he killed himself, he wasn't thinking necessarily as clearly, right? That there was something in that moment that was so overwhelming to him that made him go through with the suicide attempt that was lethal. He was able to be buried in a Jewish cemetery because, and I think that's been far more empathic to survivors, to family members and survivors. I think, but I do think understanding when you're having conversations with people, what is their relationship to suicide, and how do people talk about it, and what and ask them about that. The other piece when we really think about language mattering is this. I don't know if this comes as a surprise to people, and feel free. This would be a great time for us to unmute a little bit, but we don't say committed suicide. We say died by suicide, died of suicide. Why? Does anybody know? Is this a surprise to anybody?
It's not a crime.
What do people think? Let's look at all of these and then give me a minute. It's a suicide. You don't say it's a successful suicide death or a suicide attempt. You don't say, oh, they're just being manipulative. Just like you don't say, oh, she's a borderline or she's a schizophrenic. Words matter. So what do you think? Why do these words, this choice of words?
I think when we talk about committing something, what automatically comes to mind is committing a crime. And so this is in a different category altogether.
Yeah.
Because I think that's exactly.
It used to be that, didn't it? It used to be a crime. And I think in the UK till 1969, it was a crime to take your life by suicide. And now they've changed the dialogue and the way we use. We now say died by suicide or died of suicide, but never committed anymore because it's no longer a crime.
It used to be considered like immoral.
Yeah.
And if you're the loved one of somebody who died by suicide and you keep hearing the word committed suicide, I mean, as you said, we don't say committed cancer, right? We are very careful to say that there were things that led up to that. And even, certainly there are twin studies. We talked about things that can precipitate a suicide attempt or a suicide death. People have different levels of resilience and tolerance and coping skills and, how they problem solve. So again, even though we're talking a lot about what happens at the moment of that deep despair and crisis, it really is all of those kind of underlying principles that a person comes to the table with about how they manage extreme crises. And so when we say somebody, similarly, if we say they made a successful suicide attempt, it's like a horrible, right? I mean, and I know we said that for years when I was in grad school. It's a horrible way of describing suicide. So are there any of these that don't sit well with you? Anybody? Or that you would have a hard time changing? Sound pretty good?
Yeah, I think so.
Okay. All right. We're going to do some myths. So again, I don't know how many of these will be a surprise to you, but certainly there's a myth that no one can stop a suicide. And the fact is, if a person in crisis gets the help they need, they probably never will be suicidal again. There's a myth that confronting a person about suicide will only make them angry and increase the risk of suicide. How many people have feared that? They don't want to ask about suicide. They don't want to put the idea in their heads. They don't want to ask. They don't want to make them mad. Has that ever happened to anybody?
I've always hit it head on, to be honest with you. That was my training. So I've never had that thought that I would put that idea into somebody's head because it's already there anyway. They're already thinking about it. They don't need, there's nothing you can do to change the way they're thinking. So it's already there. So you don't need to worry about it. In fact, they welcome you asking that question because it suddenly takes the away from them, if you know what I'm saying. Takes the little pressure.
Often people don't ask because they're so afraid to ask, but in fact, people want to be asked. If it shows that you care, perhaps they can finally talk about it. It generally lowers somebody's anxiety. The simple act of talking about it can actually reduce somebody's suicidal distress and thoughts.
But I want to say I get pushback from parents. Actually, I work with kids, and I'm continually doing suicide assessments, minimally quarterly, but sometimes more. And I get a lot of pushback from the parents along that one. Why are you asking these questions? You're going to put an idea in his head.
And what do you say? What do you usually say back?
Well, what I usually say back is I'm required to do this. But that it really doesn't. It actually kind of gives it an opportunity for kids to ask for help if they need help.
I think that's exactly it. If we don't, if we don't know how to help, if we don't know the answer to that question, I will say, I also worked in schools for many years, and having asked a lot of kids, when the kid did not think about it at all, they would kind of look at you and go, no, like it was very clear that
Which is
that
very
was
affirming,
not,
that like, great, let's move on.
absolutely.
Right.
And the other thing, and when they were thinking about it, there was, right, they sometimes paused or said, well, I mean, sometimes, but I wouldn't really do it. The other thing I tell parents a lot is, we want you, first, many things. Number one, we want your child to say no, for sure. But if the only time you're hearing no, you never hear yes, then you're probably not even asking enough. When I used to do training in schools with teachers, I would say, if every time you ask, the kids always say no, you're missing people. Right? Like there has to be a pool of people who probably are thinking about it, but perhaps you're afraid to ask them. So there's somebody, so it's okay to ask more. The other thing I think it really does is it normalizes talking about suicide. So to be able to ask somebody, are you thinking about it? It's like asking your child, do I need to put you on birth control? Right? Are you having, sexual relations? Like if you are, I don't want you to get pregnant. So let's talk about birth control. So I think these are like the kinds of things we want to normalize, that say, I ask these things, and your head, where the thoughts are, is a part of your body. Just like I'm going to ask you how you're sleeping, and if you eat your green vegetables, and what you're doing for exercise. This is just another part of your body, is your brain. And sometimes your brain has thoughts. So I think we tend to separate the brain and the body, and we really need to recognize that we need to normalize that. And the more we ask these kinds of things, the more comfortable I think kids get as well. The idea that only experts can prevent suicide, we're certainly not going to have an expert every time somebody thinks about suicide. So suicide prevention is everybody's business, whether that's you're a parent, a faith leader, you work in a school, you are the coach of a team, anybody, anytime can help prevent suicide. Suicidal people keep their plans to themselves as a myth. I think most suicidal people communicate their intent sometime during the week preceding their attempt. It's not to say that there aren't impulsive events, but I think there are ways that people begin to communicate it. And certainly, unfortunately, in hindsight, we often say, well, they did say this, but it didn't click until now. I didn't think they meant it. Those who talk about suicide don't do it. I think this is a horrible fallacy. The idea, well, they just want attention, or they're being manipulative, or they always talk about that. And I think the answer is, if they're always talking about that, they're in distress, and they're signaling very loudly the type of distress they're in. It doesn't mean that they will go on to make a suicide attempt, but if that's what they need to say to get our attention, then I think we have to listen very loudly. So people who talk about suicide, they might try, and they might even go on to complete suicide. As I said, I've done a lot of training in schools, and I think this is really helpful for kids it's a myth that if a kid tells their friend, the friend will get help. And I think anybody on this call who has a teenager probably knows that, or to be true, that most young people don't tell an adult. They're very afraid about what will happen. They don't want to, they don't want their friend mad at them. And so I think when we're thinking about kind of population-based approaches, particularly among young people, I think it's very, very critical to focus on what are good secrets and what are bad secrets, right? It's a good secret. You can keep a secret that, like, Shelley likes Adam, right? That's kind of a fun secret. Great. Secrets that hurt people, sexual assault, sexual abuse, rape, suicide, getting abused at home those aren't secrets. Those are things that have to be told to an adult. And I think, and then educating, well, what will happen when you tell an adult? So I don't think it's enough sometimes to just say, oh, tell an adult, because some adults don't listen, and some adults don't do anything with the information, or they minimize it. So I think it's, I work in systems. I do a lot of systems-based work, whether it's school or community or healthcare. And so part of what I really focus on is what happens in that system when somebody acknowledges thoughts of suicide. What gets activated? What will happen? How do you train everybody to know what will happen? Asking someone about suicide will put the thought in their head. And we kind of talked about this. Asking does not put the thought into someone's head. They either are thinking about suicide, and asking is really critical, or they're not thinking about it. And I can see that Sarit has her hand up.
Can you hear me? Can you hear me? Okay, okay. Sorry that my camera is off. We just have a power outage. I just want, so I mean, totally makes sense, that one, but I was just wondering about it because, you know, there's often that thing that if there's a family member who has died by suicide, then someone is more at risk. And I have the impression that that's because it's become like a real sort of possibility in their minds. So I guess, like, obviously asking a question once isn't putting that possibility in their minds, but I imagine that that's part of this, you know, that same idea that, you know, that you can't put this in someone's mind. Of course, asking the question isn't necessarily the same as knowing of someone. That's where the anxiety comes from for people.
Yeah, so you're asking, like, how do you differentiate the idea of the thought due to being related to somebody, it might already be more likely, versus putting the thought in their head sort of as an external stakeholder? I think it's a good question, but I think the idea in a family, oftentimes it has to do with, like we were talking about, cultural norms.
Yeah.
And if a norm in your family is, you know, grandpa dealt with stress by killing himself, then that does sometimes sort of lower the bar. There's also an element, you know, like we see in the media when a celebrity dies by suicide, calls to hotlines go up, and there is an uptick in suicides. And often that has to do with the idea of, I don't know, you know, Kate Spade died a few years ago, right? Like, well, she looked like she had everything, this, you know, productive business and a great life. And, you know, wow, if she couldn't, you know, if she had to kill herself, like, what do I have to live for, right? I'm not any of those things. Same thing what happens sometimes in a school when you think somebody is really very popular, has seemingly everything. I think that's what happens sometimes in families. There, that moray or that norm looks like it's a little bit more acceptable for those reasons. But I think versus me saying to you as somebody, just a caring individual, you know, well, are you having thoughts of suicide? That's very different than, if not, that's not putting the thought in your head. That's expressing, you know, similarly, are you having chronic headaches? Are you sleeping well? It's really just asking about your health. Or, and we'll talk in a second, I think sometimes we're saying it in response to what's happening in a person's life. Sometimes when people are experiencing the really hard things that you've just told me about, it can get so bad that they even begin to think about suicide. Is that something that you've thought about? And it's not putting the idea in the head. I mean, it's really allowing an open space for a conversation that maybe felt very forbidden. Or it is, well, my grandfather did that, so yeah, I have actually thought about it, right? And then it's, tell me more. What would make, what's prevented you, or what is it that you've thought of, or have you made any attempts? I mean, so I think either way, it allows for that conversation to continue.
Excuse me? At what point in the conversation would you say that maybe it's time to think about hospitalization?
We're definitely going to talk about that. So we're definitely going to, here's my take on that. And I think this is probably a space that we could spend a lot of time in tonight, and that's a great use of our time. What I know is that in hospitals, people are not getting treatment. They're getting safety. So they're often getting reduced access to whatever their means were. But for the most part, hospitalization tends to be 2 days, 5 days, 7 days. They're not getting treatment that targets and reduces their thoughts of suicide. They're getting held in a space of safety for a few days, and then they're going to go back out of the hospital. In the US, about maybe 20% of people who go to the emergency department get admitted, because their risk doesn't necessarily rise to the level of needing to be hospitalized. And I would guess the same, but the flip of that is, for years, our approach to suicidal people is here in the US, we now have a crisis line, call 988, but call 911 or call 988 or go to your nearest emergency department if you're concerned. Primary care does that, schools do that, faith leaders do that, parents do that, right? We all take we all think we identify somebody at risk and we get into the emergency department. The emergency department, even a psychiatric emergency department, they're not doing treatment and intervention. They're establishing safety and either discharging them and saying they should see an outpatient provider, or they're admitting them for a few days, at which point discharge will say they should see a skilled outpatient provider. So the question of should we refer people to the hospital, I think there is a time for hospitalization when people absolutely cannot commit to their safety. I think there are people then have that space and time removed from their access to lethal means, just to hopefully so that they won't, because we also know there's an arc. There's a period of time, it tends to last minutes or hours, and then it kind of tends to dissipate. People's degree of intense suicidality doesn't tend to go on for days and days. It tends to arc and then decrease a little. So hospitalization for many people is can be very traumatic. They can be treated using all that language we just talked about. Why would you do that? Your life is so perfect. You're going to hurt your family. They can be stripped of their gown. They can be, many stories I know, people like barely getting food and drink and in the ER, and they're there for, 18 hours. They often are treated very not compassionately versus if you come in with a heart attack and people are very solicitous. When you come in with a suicide attempt or thoughts of suicide, not a lot of people who work in the emergency department are like not really overly kind and compassionate about that. So it can be very traumatic. So all that to say, I think that you really need to establish as an agency what your criteria are going to be to refer to the hospital, and really think hard about where you, and I understand that you do therapy and you can make referrals to therapists in your community. I think you want to make sure that the therapists that you refer to in your community, yourself and others, have suicide-specific training so that they are comfortable treating somebody with risk for suicide. And hospitalization is an option, but it should not be the option for everybody who talks about suicide. How does that sound to people? Because I think that can be very controversial.
Can I just, I'd like to just say something on that score. In the time that I've been working in Kipolim in Tikva, which is about 3.5 years now, I think as I suggested to you, I think we've only ever actually needed to call an ambulance on 3 occasions. That's when the client was actually so out of themselves, so psychotic, that there was nothing that anybody could do, and they needed to go to hospital because they needed to be treated immediately for the psychosis. There have been other times when we have advised people to go to the hospitals, and there have been times when Liami has actually accompanied suicidal people to the hospital, and they've just been basically thrown out. They've waited many, many hours. They've been mistreated by the psychiatrists, and they've been told, go home and find somebody to speak to in the morning. They don't even get a prescription. They don't get assessed, hardly, because the waiting rooms are so busy and so full of people. So actually, when we talk about sending people to hospitals, actually it can be more damaging. And this is what Julie's going to probably talk about now. It can be more damaging to the person. Our gut reaction is to save them. That's what our gut reaction is. But actually, it can be more damaging sending them to the hospital. And that's why exploring it, and the experience of Julie in tonight's session will help with build the confidence of exploring their feelings and helping understand what's actually going on for them. And then we can give them more support going forward, which generally is far easier from my experience in the past.
Thanks, Susan. Other questions about that? Because I think this is a really tricky piece for people who have relied on the hospital as their mode of where to make a referral. Connie, you have your hand raised.
Yes. Hi, how are you? Okay, so I work in an outpatient clinic in New York, and I've dealt with many suicidal clients, all different kinds, different diagnoses. In fact, I had a psychotic client call me up, during COVID, where she was decompensating with suicidal thoughts and wanting to hurt other people. I ended up helping her call the hospital, and she ended up going. we of course in our clinic we do suicide prevention, and one of the key for us is sending them to the hospital. Of course, we have a whole safety plan that we use and a whole method of how we go about it. And I create safety plans with all my clients, whoever is considered suicidal. But you know, the hospital is a place here that we do send them if it's really bad. I mean, there was a client who actually made an attempt at the clinic. It wasn't during my time, and we called the ambulance and they came and they took her. You know, she ended up coming back to us, and I ended up seeing her. But in our opinion, the hospital is part of it, is part of the whole package. It's not like, okay, if you're suicidal, we're sending you to the hospital. We have to first go through a whole assessment and see how bad it is. And we have a psychiatrist on call, so they assess them. And if it's pretty bad, then the psychiatrist will send them out. So I haven't heard in my experience any, maybe in Israel it's different, any bad feedback from the hospitals in the area. So I don't know.
Sander.
So I just wanted to really ask some of the folks that have been working with Kipalim, what has been your experience and what is your sense of what resources you have to direct folks to in Israel? Just to think in terms of, for the concrete application of what do you need to know? Do you have that information? And of course, that's a question that is directed both at the group, but also back to Susan to think about what resources should be taught and offered to folks volunteering.
That's partly why we're having tonight's session, because we would like everybody to be trained effectively in suicide prevention. I think it's very important for anybody on the helpline or anybody within our organisation, even in the therapy side, that they update their training on suicide, because it is something that we ask as soon as I do an assessment. I always ask that question. So the therapist or the helpline or the therapist is aware if there has been any history of suicidal attempts in the past or recently. I always make sure that's asked as well. I ask what their treatment program was. So I do go into that with them. So, because I do have people on the team that I know don't want to work with suicidal people. So that's why I'm very careful to make sure that those questions are always answered. If somebody is actively suicidal, then we always check if they have a psychiatrist, and we make sure that the psychiatrist information is on file so that we can refer and the psychiatrist can refer to us as well. It is actually very rare that we get somebody who is literally on the bridge, if you know what I'm saying. It's very rare that happens. There is a suicide helpline in Israel called Iran, and that is their purpose of being there. It's a challenging thing to go to them, but they are there by the government and paid by the government to have an emergency 24/7 suicide helpline, which most of their callers are not suicidal, but it comes into that. They are recognised as doing that, and if we are, that's the phone number that we will also give out as well. How effective it is, I can't answer that, because, you know, I have called the helpline and I haven't found it effective, but as an organisation, they're recognised by the government as a provider. So that's the number that we would give out as well to somebody who doesn't need to go to the hospital again, but needs that little bit more through the night, maybe, of support, either calling our helpline or calling Iran if their language is available as well, and that's important to state as well. Hebrew is the first language of Iran, so that for our population is very challenging, because when you are feeling that way, your mother tongue is the most comfortable language for you to speak in. A large proportion of our client base is English speakers. We do deal with other languages, but English is the predominant language that we have. So that's that's where we're at the moment. We do aim to have trained supervisors in the background of every shift. At the moment, my name is up there. I've done a lot of suicide prevention work, but going forward, this is stage 1.
Suzanne, I thought I saw you raising your hand. Did you have a question?
No, I was just going to make a comment. I don't know how relevant it is now, but I worked in Paris, France for a long time. And the French system is actually quite excellent when it comes to working with suicide. And we actually take people, we don't have the same insurance restriction as we do in the United States. So people actually get help through being admitted to a suicide, quote unquote, prevention unit, where they stay for up to a month to 2 months, and they get intensive therapy depending on the hospital you're at. There's a psychiatric hospital in Paris that's designated for that. So it varies. I would imagine it varies from country to country. But that's been my experience relative to the United States, where you're in and out, and it's often extremely traumatizing.
I had a comment and question. I don't know if I can be heard. Hello?
Yep, we can hear you. Yep.
Oh, great. Thank you. I don't know how to raise my hand on the thing. Well, I worked in a system that was actually very comprehensive, and we had a crisis line with many, many suicidal clients. And I had one thing that did work well was when the client could not, commit to a safety plan, and the situation was deemed to be imminent. I was LPS designated, as were a lot of my staff, and that meant in America, that means that you're designated to hospitalize a client. So we also worked with hospitals directly with the psychiatric units. So we had relationships with them. So if I felt somebody was, needed to be hospitalized, I would write the hold and contact the psychiatric team, at that hospital. And so it was a fairly collaborative approach, and, often less traumatic than just going to an emergency room. But I wondered, because I had to supervise a lot of clinicians about that, and I always got the question of, what do you think of contracts? Do you like them, or do you not like them? Suicide.
No suicide contracts?
Yeah, no suicide contracts.
They're not I would never use them.
Yeah, no, I didn't use them either, but many people are trained to do that, and I often, said that just doesn't make any sense.
No, and they should be told, like, that's how I was trained too, 30 years ago. But they're not used now. That's really safety planning is, as right as you just said.
Planning also is very helpful. Advanced safety planning, having an
for sure. But I think with the contract for safety, it's that idea, it may alleviate the anxiety of the clinician, like, well, the patient promised me.
Right, I know.
They won't kill themselves. But you've not given them any tools to reduce their suicidality. And so you've done nothing, and it's not a legally binding document. You've given them no tools to mitigate their suicidality. And so you've made yourself perhaps feel better, but it actually is, it's incredibly counterproductive, and the first thing should be like, no, don't throw it away and don't ever use it again. Yeah. Let me actually change. I think it looks like we went through people's questions. So let me move on. And I can see people typing in chat too. So thank you. I saw a few articles and some other things. So I want to thank you. Okay, so some strong predictors of people who are at risk for a suicide attempt. People who have already made a suicide attempt, talking about suicide, making a plan, Those who have a strong wish to die are preoccupied with death. You might see it in their thoughts or their music or the things that they read or listen to. We know that there is a link between depression, particularly as it relates to that sense of hopelessness or withdrawal or feeling like a burden to others, very disconnected, lonely. Those are the pieces that have more to do with than just the having major depressive disorder. It's really those pieces that are related to lack of connection. Substance misuse can be a strong predictor because it's, there's a very lethal triad, which is if you're having thoughts of suicide, you're using substances, so you are reducing the likelihood that, because you're mitigating sort of your barriers that would have held you against making an attempt, and then having access to lethal means. So if you have access to a gun, that trio of using substances, thinking about suicide, and having access to lethal means are people that you should be very concerned about. And then another predictor is being the attempt of a friend or a family member. And we kind of even talked about that, the idea of, I thought Julie kind of had it all. So if she did it, I don't know how that makes me feel anymore. There are verbal clues. I've decided to kill myself. I wish I were dead. I'm going to commit suicide. I'm going to end it all. If such and such doesn't happen, I'll kill myself. And sometimes they're not quite so blunt as this, but certainly when people talk like this, we want to say, tell me more. We want to take it seriously. Did somebody just say something? Nope. Okay. And then there are the more indirect ways of talking about suicide. I'm just tired of things. I can't go on. People be better off without me anyway. Who cares if I'm dead? I just want out. I can't do this anymore. I won't be around much longer. Pretty soon, you won't have to worry about me anyway, so don't worry about it. These are those veiled comments that we really want to better understand and ask more about. There are behavioral clues. As I said, making a past suicide attempt, having access to a gun, or we know somebody's stockpiling pills. There are ways, and these are things that lead into how you make a safety plan. A lot of you have already mentioned a safety plan, right? How you write prescriptions can be one way to reduce access to a large amount of pills, or using pill packets. So even just the act of having to pull out one pill at a time can kind of slow down somebody's access to pills. Giving away prized possessions, having impulsivity, or somebody who's doing a lot of increased risk taking. Oftentimes, and especially among kids, you won't see depression sort of in a Hollywood kind of way, laying in bed and crying all day. It'll come across much more like anger or aggression or just strong irritability. Cutting isn't always related to suicide, and sometimes people they don't have thoughts of suicide at all, but they do. Cutting, those things where they're scratching their skin as a way to alleviate pain, but it certainly is depicting distress, significant distress that we want to ask about. It doesn't necessarily mean that they are trying to kill themselves, though. Kids, again, running away, truancy, or having a sense of perfectionism. These can be things that somebody who might be at more risk for suicide may have one or more of these behaviors. And then there are situational clues, things that when somebody is experiencing these events, these would precipitate perhaps, you're a crisis line, but it might be some of these things that would precipitate a conversation. Getting fired from a job, the loss of a relationship, significant family problems, and alienation, the death of a family member, a friend, or their own diagnosis of a terminal illness or something that feels very insurmountable. Financial problems, sudden loss of freedom, fear of punishment. This starts to get a little bit into kids, that sense of you're going to be grounded, or what if people find out, that humiliation in front of peers, or feeling very embarrassed, that things that we see happen through social media. Fear of punishment, getting arrested for something, or fear that you're about to be arrested for something that can precipitate a suicidal crisis. Being the victim of an assault or bullying, being attacked, are certainly things that can lead to somebody's thoughts of suicide, or being a fear of being a burden to others. So we've already, I don't know if I missed anything in some of the clues that people have also encountered that they want to put on the table before I go on.
I understand that older men are at very high risk for suicide,
That's true.
more so than women in particular.
A lot of that, I think, is related to loneliness.
Mhm.
Yes, they're one of the highest risk groups. Other thoughts? All right, so now we're moving a little bit into some of the things that some actual skills to think about. If sounds like most of you are doing this already, and this isn't new, so feel free to add your own thoughts here. But I want to preface it because I myself have experienced this, and I think for people who don't feel comfortable, or it can be hard to ask very directly about thoughts of suicide. And so I think sometimes people back into it by saying things like, well, you're not thinking about suicide, are you? Or even on standardized risk screeners. So there are standardized screening tools that are written in such a way that the way you ask should be verbatim as it's designed on the tool. I know that sometimes nurses or others will use that tool and then say things like, I'm really sorry I have to ask you this, but we ask everybody. So you're not thinking about suicide, are you? Things are going fine for you, right? You're not having any issues. And I mean, we laugh because it sounds like everybody in this call would never do that, but that happens day in and day out. And imagine if you are having thoughts of suicide, you're basically saying to the individual, do not tell me you are. I am making it clear. I do not want to know. If it makes me uncomfortable, I don't want to know. I don't know what to do if you say yes. So I think it's important that we be very clear. You don't say things like, wow, you're just kidding about killing yourself. You would never do anything crazy, right? Like you would never do anything stupid, would you? And even the question of, are you thinking of hurting yourself? Hurting yourself is not the same as killing yourself. It's not the same as thinking about suicide. We even just talked a little bit about self-harm. Sometimes people say, or they're thinking, oh, I'm not going to hurt myself. I'm going to be dead. And then it won't hurt at all. So we have to be, I think people tiptoe into it because they feel like it's easier and more comfortable. But then they're really not getting the information that they need, and they're not having the true conversation that they're looking to have. So part of asking is listening very effectively, offering your full attention. We don't want to ask somebody if we don't have the time and the ability to be fully present, letting the person talk freely, certainly not judging. Oh, I know lots of people who have been through that. You'll get through that too. I think there's a balance here of trying to offer hope and understanding, but not trying to act as though you can solve the person's problems or just cheer them up. I think suicide and those thoughts of suicide in and of themselves is the solution to whatever the individual feels is this perceived and insolvable problem. And so the idea that they just have the ability to talk about it and together can think about a strategy that will help reduce their thoughts of suicide is great, but without being judged of like, you'll have plenty more boyfriends, or I know it seems horrible now, but you'll be fine in the future. I think trying to balance that with, I know people who have been in this situation before, and if you trust me and will work with me, I know that it may not feel like it right now, but it can get better. Right? It's a little bit of a different way of offering hope and understanding without trying to say without minimizing the person who's telling you, but it doesn't feel like that to me in the moment. It's offering them hope. I can kind of hold you and remind you that there are effective treatments if you'll allow us to work together on those treatments. And I want to make sure that we kind of touch on LGBTQ individuals because they are at greater risk for suicide, particularly youth, 3 times the rate of heterosexual youth. These actually might even be a little bit outdated, but 5 times as likely to make a suicide attempt. And often that's a really serious suicide attempt requiring medical treatment. Not surprisingly, a lot of individuals come from families who reject their coming out. And so that can feel, then that increases their sense of loneliness and lack of connection. And so it makes sense that kids who are feeling and young adults who are identifying LGBTQ, not to mention just getting harassed or abused or, having challenges at work or in other kinds of relationships. But so certainly understanding somebody's status here, and, I don't have a slide on this, but I think in Israel, and again, this isn't an area I want to speak too much about because it's not my expertise, but here in the US, we've encouraged primary care physicians to really ask about veteran status. And interestingly, we have people ask about veteran status here because so many veterans have access to guns. And so just an understanding that they understand how guns work. And in the US, it's certainly different than in Israel, where people, have army service and then have reserves. But I do think, I leave that to you all to talk about more, but I do think having an understanding of access to lethal means is really critical. So as you're understand I don't know about the Olim because they may or may not have served in the military. It's, depending on the age that they come, but that would probably be a question I would want to understand and unpack a little bit too.
That actually does come in under our Lone Soldier program, which perhaps may not feed directly into the helpline that we're talking about, but certainly for the therapists on this team that have joined us, because the lone soldiers, we work with a lot of lone soldiers who are in the army, who have access to guns, who do at times feel very suicidal. They don't see any other way out. So that gun point is very important. And what happens in those instances, if we're actually getting into the depth of that, then we, as in myself and the director of our Lone Soldier program, Mike Meyerham, who is here tonight, can speak with the army. We can write to the army. We have contacts with the head of the psychiatry and the head of the Olim division, requesting that soldier's gun is removed from them. As we've discussed with you, Julie, the other day, that we are very aware that this is how the army has actually started to reduce the rate of suicide, although it has climbed up again. But the risk of suicide with lone soldiers is quite high because they have no families, they have very little support here. And people genuinely don't know that they are suffering. They don't find the right resources. So that tailors in very nicely with our Lone Soldier program. Many Olim, standard Olim, and standard Olim, what I'm saying is people who haven't done service in the army, access to getting gun here is not easy. Depending on the area of the country you live in, it's now becoming easier. They're encouraging people, but you have to have been in the country for so many years and meet certain criteria. So guns in Israel are not easy to get hold of at this, even with the war on. It's not so simple as it appears to be in America. So there is, I think, a less risk factor here with that.
Oh, thanks, Susan. Yeah, I'm glad it's on your radar.
Yeah, it is.
And wrapping up, this was a slide about suicide in the transgender community. Again, very high frequency of suicide attempts for all the reasons that I was just saying. I'm kind of moving into suicide risk assessment and safety planning, things that you all say you do now and are pretty comfortable with. So I will go through some of this relatively quickly, but would love to just pause and see if there's any. I'm mindful, I'm not sure even if we wanted to go past the hour, Susan, but I'm mindful that there may be questions that have come up and just want to pause. And somebody has their hand raised, but without a name. iPhone 386.
I'm sorry, it's Suzanne Gavin Gould. I have COVID. I'm not showing my face, but I have a question regarding. I am not sure if this is fact or a myth, but my understanding is that very often patients who have been speaking of suicide and who have suicidal ideation, family members often see them getting much better and thinking, okay, the crisis is over, and all of a sudden there's a suicide and the family is shocked. Can you speak to this at all?
Yeah, I mean, it could be a few different things, and I welcome the other expertise on this call as well, but a few things. One of the periods that is the highest risk for suicide is in the few weeks after discharge from the hospital. And so I think the family often feels like, whew, thank God they were in the hospital and they probably gotten really good care. I think the individual often feels like they were taken seriously, and they want to believe that the hospital will have been a place where they will have had a chance to get their thoughts of suicide addressed. And then they come out and nothing's changed. The things that precipitated the hospitalization are just as bad as they were, but their family often, or their work, may feel like, but you were in the hospital, so why aren't you better? And so we know that period of time, those few weeks after hospitalization, is a very, very high risk. So that's one thing that you may be speaking to. The other thing that I think does happen sometimes is people have a sense of calm because they've made peace with the idea that they're going to kill themselves. They've put things in order. They have made their decision. And so you see that sometimes when people have been started on or they now have enough energy to actually go through with the suicide attempt. We see that sometimes when people, it's one of the reasons there can be a concern about going on an antidepressant, is because for somebody who truly just didn't have the energy at all, they now have just enough energy, and it may look like it's a bump and it's great and they're starting to kind of come back to themselves, but in fact they've given themselves enough energy to go through with the suicide attempt. So those few things can sometimes precipitate what the family thought was great. We're coasting and things look better, and then in fact there looks like this very impulsive attempt. I don't know if anybody else, if that answers your question, or if other people have had different experiences where they see that play out.
Thank
and
you.
then
That's
Suzanne,
Yeah,
Suzanne,
that's definitely a risk factor. I think you're as Grant, you're also speaking to the family systems dynamics. A lot of times the suicide is such a stigmatized and sort of split off, dissociated concept, that as soon as things look a little better, everyone kind of wants to pretend everything's fine. But when things are getting better is the time where you really need to maintain the vigilance, right?
Yeah, no, I thank you. I think that's exactly, it makes sense.
I've seen from experience working in prison service exactly that situation where if you're not on top of them, suddenly they're giving stuff away, their life is changing, the way their habits are changing, and suddenly they become calmer and happier. And I've had the experience of where I've seen a man in the prison during his lunch break. I've had a conversation with them. They've taken their food back to their cell, and 15 minutes later, the alarm bells are ringing because they've taken their lives.
Yeah, I think that's also shown in some of I shared a link where at Austin Riggs, which treats people with very severe problems, they interviewed people who had basically by luck, survived what should have been lethal suicide attempts. And they do report that they felt this relief. And they also report having sort of a split consciousness. One part of them, which you don't necessarily have access to, and they may not have access to if they're dissociative. And then the other part of them are sort of in conflict with each other. And so that also can be important therapeutically to get in touch with all the different parts of the person, which, requires maybe some specific training in the treatment of dissociation, but often is comorbid with trauma, and especially childhood trauma survivors, as we know.
Suzanne, I see your hand up.
Hi, thank you, Julie. Question about how to deal when there's a moral question. For example, I've worked with people at the beginning of the AIDS epidemic who came into the ER at UCLA. I remember one person in particular was screaming, "You don't have a right to tell me I can't take my life because I'm suffering. I know I'm going to suffer." This was prior to the advent of any of the medications that prolong people's lives at the beginning of the 80s, mid-80s. And also the research I've done with war journalists, particularly photojournalists who suffer from severe depressions and trauma more so than regular war journalists, because they're looking through a camera lens up close. They're seeing an atrocity up close as if they're right standing there, and they feel tremendous guilt that they can't intervene. And so I've worked with war journalists who've said that they've wanted to die, that I don't have the right to tell them that they can't die. They can't live with this moral indignity. It's been a real issue. So I'm wondering how you would address those issues.
I mean, I think even in the lived experience community, there's a real split where there are people who have survived their suicide attempts and have said, I'm grateful for the treatment that I got because I now have the hope and I realize that I'm happy. I saw somebody posted Kevin Hines' book. You know, Kevin is a great example of somebody who survived jumping off the Golden Gate Bridge. He does a lot of public speaking. So I think that's a piece of it. I think then there's also a piece in the lived experience community who wants to be able to hold on to the idea that if they want to kill themselves, that's their prerogative. And that idea of lack of, control is what they don't want. Often they're exactly like others. They've been traumatized. They don't want to be told, they don't want to have that taken from them. I believe there are treatments that can work for PTSD, even really severe PTSD, war trauma, other types of sexual abuse, dissociative disorders, profound depression. I think that there are treatments that can work, medications can work, and there are people who live with chronic suicidality. As I said, I think that sense of suicidality waxes and wanes. It doesn't always remain at a 10 out of 10. And so sometimes helping people understand that living at a 5 out of 10 may be where they live, or a 7 out of 10, but it's not a 10 out of 10 every day. I think it's, I'll turn to others and allow them to share their thoughts. But I think taking ownership over somebody to say, no, this is absolutely forbidden. And, I think my experience as a clinician is to say that's always an option, right? I can't take that from you. That is always an option. But if you will allow me, I think we can explore it together. Are there other ways you can live? Sandra, what would you add?
Just story from disaster response experience. I always go back in these conversations to an experience of speaking with the Sri Lankan fisherman survivor of the tsunami, who was considering dying by suicide. And we struggled when we realized that we are in a different cultural environment, our team, where we really couldn't fall back on what was a well-worn path of suicide is wrong when you think in terms of Judeo-Christian framework around it. So we thought more about how do we address it. And in a conversation with this gentleman, we talked about the efforts to create meaning and thinking about his potential contribution to his community, where he has lost all of his family, but there are other families who lost their breadwinners. And thinking in terms of not focusing on suicide being wrong, ergo can't happen, but what would be the loss suffered by the community if you're not part of it? And that's what worked. So ultimately, it wasn't the specifics of it, but really suspending the judgment, and really removing the judgment from that conversation and thinking and talking with the person about this, in fact, is your reality. And these are, in fact, credible and real considerations. What can we do together to help you be here in the most fulfilling way possible? So shifting away is something that I try to think about when I engage with patients in these conversations. I don't know if others find that perspective helpful.
And I actually think that's a very valuable comment, Sander, because in our organisation, we are dealing with people from all over the world. So culture does play a very large part in the way that people present to us. So that really is kind of a really valuable comment, because what might be acceptable, even though our client base is, I would say 99% Jewish, because there are some non-Jewish people that are in our client base, even though Judaism does teach certain ways, but the culture of the country they come from also impacts on their religion as well. And some people aren't necessarily religious. So that actually becomes very apparent. So we have to be accepting that people, whilst they may be Jewish, may still culturally have very different views about suicide.
I wasn't sure if I saw somebody else's hand up.
I think you do.
So a few tools. I gave you some links in here, and one is called the Patient Health Questionnaire 9, PHQ-9, ASQ was created here. These are all created here in the US. The Columbia Suicide Severity Rating Scale has multiple versions. I think, you know, these are all free. They're all publicly available, common source. I think the bottom line is you want to use a screening tool that is standardized, that everybody understands, that you have been, you have reviewed and have agreed will be your tool of choice. I think these have been normed in such ways that we know that the research, when you use a standardized tool, it's better than clinical. It's in addition to clinical judgment, but it does not, you don't use clinical judgment in lieu of a standardized screening tool. Once somebody screens positive for suicide, you want to do a full risk assessment, and that the Columbia Suicide Severity Rating Scale has a full risk assessment as part of it. This is the way it really looks at ideation, behavior. It includes different parameters of suicide behavior. How intense is it? So kind of looking at the ideation and how intense is it? Do they actually have suicide behaviors that they've engaged in? Like, did they make an attempt or was it interrupted? Did they make an aborted attempt? Are they doing preparatory behaviors? There's a measure, how lethal did they think it was? I think that's a really helpful question, right? If somebody thought that they were going to die because they took 5 Tylenol, that's really critical versus doing something that they didn't actually think would kill them. I think understanding what they thought the outcome would be. Some of you might, somebody's has a question? So the CSSRS is a structured tool. You can have access to it, and it has a scoring mechanism, and it scores people into red, yellow, green. Again, there are different tools. Different clinics will use it because there's a version most recent, there's a version since last attempt, there's a version lifetime. A lot of agencies use this. Not everybody is enamored of the Columbia tool, but I think having access to a standardized tool as an agency and as a group will begin to give you both data to kind of understand what is your population looking like, and will help you to tell the story better of what are the decision making and the workflows that you are using as an organization. So I would encourage you to use the Columbia as your tool and ensure that you're tracking on this in a database, because you're getting to the question of when do we hospitalize people. I think the Columbia kind of helps you think about what is the appropriate level of care. You want to also use your clinical judgment. You want to use warning signs. You know, I wouldn't use, if you don't feel like somebody's being truthful and they're not answering honestly, but your gut is telling you that the individual is still a great risk, we certainly wouldn't want you to lean so hard on a standardized tool that says, well, you know, they said no, so therefore I let it go. And I don't think anybody on this call would. I do think it's a marriage of both. But I think it also gives you a tool to have that conversation because sometimes our anxiety goes up during a call with a really challenging caller. And so I think it also gives you the tools to say, oh, this way I didn't leave anything out. And that way, again, you're using it at every time with every visit. You can also, if you're getting repeat callers, part of what's really powerful, I think, is knowing for an individual what is their level of risk today versus what their level of risk was like last month or the last time you spoke with them. And by using a standardized tool, if you're able to collect data on your individual callers, should you get repeat callers, it'll also give you a way to really compare in that, what is the appropriate level of care? Because you may say, you know, Julie seems really high risk, but I've spoken to her 3 other times, and actually, according to the Columbia and even just the things she's saying, she's actually not as high risk as she was before. And that idea of comparing risk to the individual as well as comparing risk to the population that they come from, I think both are really powerful ways, right? Julie, as a middle-aged white woman, mom, might seem like I'm at really high risk, but if you've talked to me 4 times, you may find Julie kind of lives with chronic suicidality, and she's not as at high risk as other times I've spoken to her. And I'm sure you have tools for how you document your decision making. But again, that's a space then you really think about not just patient reported, but why you made your decisions based on using the tools you used, but also some of these other pieces of background or having spoken to people in the past. As you're doing your risk assessment, I think it's really important to think about how are you allowing the individual that you're talking to. You want to ask directly about thoughts of suicide. We went through that a little bit. Are you having thoughts of suicide? Tell me about them. Are you thinking about killing yourself? Tell me more. We want to excuse me. You want to know the individual's unique stressors that have led up to them thinking about their thoughts of suicide. You want to certainly minimize, you want to avoid minimizing the nature of their threat. Like, oh, that doesn't really sound like something that would kill you. Again, really the idea, does the individual think it would kill them, or how intent are they on their thoughts of suicide? And certainly that not judging an individual. And it's really important to understand what their barriers, both to treatment as well as their individual barriers. People have tremendous ambivalence when they think about suicide. We are designed to keep ourselves alive. And so sometimes we have to really think about both what are the person's reasons for dying, but we also really want to explore a person's reasons for living. What are their barriers? What are things that would keep them alive, and other sources of support? That could be family. Sandra was just talking about making contributions to the community. It could be a pet or a dog or a class or a book club or a coffee, right? I love waking up in the morning and just having that coffee, and that's what I look forward to. So any things that we can try to pull out that incorporate what a person's reasons for living are, and ideally thinking about what are the supervisory opportunities within Keep a Lean for both challenging calls or level of care calls, and are you all on the same page, or how do you make these decisions, especially in crisis calls where you're all not sitting in the same facility geographically at the same time. If you're taking calls from home, that can also be incredibly challenging. So even having in place, what are you going to do for yourself when you end these calls to ensure that you feel comfortable, confident, you have a chance to decompress or walk through your own decision making. I'm going to go through safety planning momentarily. Certainly, everybody seems to be already using safety plans. We want to neutralize the plan that the person has, if possible. We want to get guns or there are other means, if possible, out of the house. We want to make warm handoffs to appropriate providers, which would include really educating the individual on what happens, even if that is that you've decided that they're going to go to the hospital, really explaining what can they expect. So if you know the hospital where you're making the referral, what can they expect? How long are they going to be there? If they're going with a loved one, or if they're going by ambulance, what that might be like for them. So it doesn't have to feel, things that they might be able to ask for. Do they really have to change into a gown immediately? Do they have to have their phone taken away? Things like that. And the degree to which family or their loved ones or their peers can be involved, I think is really, can be incredibly important when we're thinking about how do we increase somebody's safety. When you're doing this through a phone call instead of face-to-face, it can be even harder. And so talking about safety plans and who's available immediately. One of the things, and this may be part of your agency protocol, but when somebody calls, maybe where are you calling from? Who are you with right now? Could I get a callback number? What is your address? Who are you with? Could I get their phone number? Are there people that we can share you know, about what you're going through right now. How would we be able to reach out to them? The degree to which that you're able to incorporate that from the get-go, so that you're not finding as a conversation goes on that you're engaging in a power struggle with the individual, and say this is part of our agency protocol, you know, in order to make sure that we keep you safe, and, you know, we're able to do what is necessary to keep you safe. This is just part of our protocol. So a suicide safety plan, there are different versions. One is called the Stanley Brown template. One is called the crisis response plan. There's a wellness plan. Each of these has a robust body of research behind it. The bottom line is they are meant to be a prioritized set of coping skills that allow an individual to demonstrate self-efficacy over their thoughts of suicide. It really is that, and I think it sounds like everybody's already aware, but it really replaces that idea of, oh, you're thinking about suicide, we have to call 911 or go to the hospital. It really is what are the steps I can take to keep myself safe without having to resort to going to the hospital every time. So, and they also really need to be individualized. Safety plans are meant to really reflect each individual person's unique set of coping strategies, just like each individual person's journey to having thoughts of suicide is their own and unique. The way in which they're going to manage their thoughts of suicide shouldn't ever look the same. So if you pull out, do a chart audit of, you know, the last 10 safety plans you do, they shouldn't look the same. Even, and part of doing a safety plan, right? If I say that reading is really helpful to me, part of doing a safety plan is the specificity. So it's not just that we've completed a safety plan. All right, when I start to feel stressed and I can't sleep at night and I'm starting to feel upset, well, then I'm going to use coping strategies like reading and going for a walk and petting my dog. But rather, I'm going to read the latest version of People magazine that I keep in my bathroom. I'm probably going to read it with a cup of coffee with hazelnut creamer, sitting on my couch. I like to wear my fuzzy slippers, right? Like, you really want to paint a picture for the person of what would using their safety plan look like. I want to go for, it helps me to get out of my house because now I'm very unlikely to kill myself in public. Where would I go? Starbucks. Which Starbucks? I would go to the one that's at Four Corners. What are the hours of that one? Is there a particular table I like to sit at? What is it I like to order? What do I have packed in my bag to go to Starbucks? Do I walk there? Do I ride my bike? Do I take metro? Do I drive there? You really want to create for the individual this idea of how unique their safety plan is for them, so that when they are in crisis and they pull it out, they have already thought through, these are the things that I know make me feel more comfortable. And that's why it really would look so different if it's my safety plan versus Sanders versus Susan's, because even the different ways in which we're going to enact our coping strategies should be very different. It should be very unique. It should be very collaborative. It can take, I mean, a really good safety plan can take an hour to create. It could take more than that. It certainly doesn't take 6 or 7 minutes. So it really should have this sense of being highly collaborative, highly meaningful, individualized, and in and of itself, it's an intervention. So that's what's the most important piece of it, is that it was actually studied as an intervention, because the intervention of doing this can also reduce somebody's distress. And then it has different levels. So it has where we want to document it, we want to think about, let me pull through. Here's a sample safety plan, right? Step 1 is, what are the warning signs? This is the Stanley Brown template. Each individual's warning signs, and what are my own internal coping strategies, the things that I would do to take my mind off of my problems that have nothing to do with calling another person. They're just my own set of strategies. Is it physical? Some of the examples I was just giving you. It could be people or social settings that provide distraction. So it actually could be where I leave the house. It could be my husband. And in this case, it's not that I'm yet asking my husband for help. Or it may be people in my book club. I would just reach out to my book club and ask people what we're reading today. It could be that I need to ask people for help, but it doesn't mean when I say to my husband, you know, I'm feeling really distressed, I'm really having a lot of thoughts of suicide, that his reaction should be, let's call your therapist, or I'll take you to the emergency department. ideally, and this is where I think it can be really helpful as a crisis line, if you are able to, or as therapists, to get access to the individuals in that person's network for who they might list on their safety plan, is to educate them. They're certainly want to be a resource for their loved ones, but they're probably terrified and they don't know what to do. So if they get this phone call, what they're thinking, I don't know what I'm supposed to tell you. And so your job as the therapist or as the crisis line, where you can, is to say, is to have a conversation. What would you, Julie, what would you like Adam to do when you're feeling this way? I want Adam to pull out my safety plan. I want Adam to go for a walk with me. I want him to offer to watch a movie with me. I want him to make dinner that night, right? Just things that may be helpful to alleviate my thoughts of suicide, but he's also been informed and educated, and he's not looking to say, I don't know, we should probably call your therapist or your psychiatrist because we've panicked him. Somebody needs to educate him, or parents, or anybody who's listed. When we get all the way down to step 5 is when we start thinking about the professionals or the agencies we need to contact during a crisis. So I think that's really important, that the initial thing is not that that's the people we call, but we do want people listed here. Where would we go? What's the clinician's name, number? How do we reach them? Or some other type of emergency services. Here in the US, we have the suicide prevention hotline. Now it's actually this, I know that they hadn't updated this, but now it's 988. In Israel, it may be your hotline, or it may be the other hotline we were just talking about. And then step 6 is really about reducing access to lethal means. What is it that we can do that you need to discuss as part of the safety plan that reduces access to lethal means? Do they have access to a gun? Are they talking about taking pills? What is it that we can do that would ensure during this time of acute distress that we have removed their access?
Can I just interrupt? Is that possible?
No, go for it. Yeah.
No, fine. I just like to ask you, because I know some people are leaving because they're going on to shift and one thing and another. How far are we away from the end? Or maybe we can complete this another day. I'd like your feelings on that one. Because it's really fascinating. I don't want to hurry you. That's why I'm saying this to you.
I think the majority, I have a handful, we're really towards the end. The majority of the slides I have kind of talk about safety planning in different ways. And I think we're kind of covering them, and it sounds like your colleagues know. I'm happy to go back over it or send these slides out to you. What I'll do is skip a little bit. I will, to summarize pieces of safety planning, I think that you do it with every client, even if they're not at risk for suicide. Perhaps not quite as in depth, but I certainly think that talking about, you may not be suicidal now, but what if you were suicidal in the future? Let's just think about what you would do to keep yourself safe. And that's just a basic plan. I think it's helpful. It kind of normalizes, again, some of this conversation. It normalizes the idea that you have a right to think about what to do when you're in distress, and you can update it as time goes on, or if your distress increases. It shouldn't be presumably the same safety plan I have today, may not be what I would have used last week, last month, last year. So I think this is also something that has to be updated routinely. These are just some things about how I think they're kind of obvious about when we've covered a lot of them. I mentioned that suicide risk fluctuates over time. Oops. This is sort of an example.
I like that.
And I just walked through what a safety plan is. So this is crisis response planning by Craig Bryan. It's pretty similar to a safety plan, and I would encourage you either pick one as an agency, again, in the spirit of having something to refer to and discuss, so that it feels from supervision or from kind of chart audits, you have similar forms for each individual. So these are fairly similar, and I think both of them have different merit. So I think there are different reasons people like both, but I don't have a strong feeling one way or the other. This is the different pieces. I think the difference in the the crisis response plan. This is what's in here. I think the difference a little bit is that this goes a little bit more into reasons for living, a little bit different, and it goes a little bit more into obtaining commitment to use the crisis response plan. The majority of the rest of it is pretty similar to the Stanley Brown. We talked about it's really important to talk about reasons for living, I think in crisis calls especially. And I think Sandra gave a great example of why, as people are very focused in having tunnel vision about what it is that is causing them to feel so hopelessness. I think if they can activate 1 or 2 reasons for living, I think that that's really critical. And I think that's actually the purpose in many ways of having crisis lines, which really gets at hope. And I think that idea that we really want to find really small nuggets where we can drop hope into conversations. This is, is hope because of the goals that they have, very small goals, right? Doesn't have to be these sort of enormous things that they plan to accomplish, but some type of goals, something that they can feel a sense of responsibility, care for others, commitment to others, and being able to set, small goals, small pathways towards achieving those goals, and the ability, in fact, that they can achieve those goals. We certainly, when somebody's, thinking about suicide, don't want to talk about like a graduate degree and the surety of getting into graduate school, but the idea that this is something that they're passionate about and that they can explore. We want to find ways to help an individual feel that they have a pathway towards getting to meet those goals. And everybody has some types of dreams that have not yet been realized. And I think that is the conversation that we want to have, is that as long as they're alive, that they have the opportunity to fulfill some of these plans or goals or dreams. And in fact, I bet if you look back on your life, there were probably other things you didn't think that you would be able to achieve. There were probably other dreams you never thought possible. Can you tell me about some of those? Because I imagine that you may have felt this other way in your life as well. And so even as part of that call, thinking if we could select a small task that you could accomplish, and you would know that things are a little bit better, what would that be? What are some of those small tasks that you might be able to accomplish that we could begin to think about today? Because I think that begins to give people concrete steps and begins to see that maybe it is manageable and maybe it is doable. And our job in crisis calls or with people at risk for suicide in general is to hold hope for them. I think they've lost their hope, and I think, it's okay to hold that hope and say, I'm going to hold that for you a little bit right now while you're struggling. But I believe that through some of the things that you're sharing with me, that you can also get to have hope as well. Stacey Friedenthal is an author. She's a therapist here in the US, and I don't recall if I put her book in as a resource, although you can find it here. It's available on Amazon. She just wrote a second book about loving somebody with suicidal thoughts, and it's so well written. And so if you haven't read anything by her, I would encourage you to. She also has a website, speakingofsuicide.org, and it's just such a well-written, accessible website, I think, for people in this field. To feel, and actually something that you can even share with people who are experiencing their own thoughts of suicide or their loved ones. I think she herself has struggled with thoughts of suicide. Her child has been hospitalized. So she really knows from what she speaks. And I think she gives very practical, very meaningful tips.
Oh, thank you.
The last thing I had was things like a hope box, a survival kit. And this is that, how do you put time and distance when somebody's thinking about thoughts of suicide? What is it that you could do? Like they do lock boxes in the military. They probably have them available in Israel. Where is it that you could store the lethal means? Where is it that you could store messages of hope, pictures of your loved ones? The reasons your safety plan, the reasons I want to stay and live. How a hope box is really, what is your toolkit that in the moment of crisis would remind you that you have hope? Photos, souvenirs, writings, things that have kept you alive so far. What are these symbolic things that sort of give you that moment to reflect and respond? that you can have hope for the future. And what is it then, as far as, I think I have lockboxes on here, what is it that you could use as a lockbox? And I would encourage you to find out if those are available near you, that a gun, ammunition could be stored separately. It could be out of the house. But we know that when you have to, I know people who have put their gun in a block of ice. They froze it so that they, knowing that they were in a period of time where they were really struggling with thoughts of suicide, by not being able to access their gun until that they could defrost the block of ice, meant that it would give them that time to kind of think about their safety plan and come down from that acute distress. So I think people are creative, and that's part of our job, is to say what would help to give you that time and that space and that distance, both those things that fill you with hope and remind you why you haven't made suicide attempts or what's prevented you in the past, as well as what we can concretely do to keep access to lethal means distanced. We've already talked about hospitalization, and and this is really a matter of when somebody's making an attempt, or they absolutely report that they have no ability to stay safe. And I think we explored this a lot, or psychosis, mania, severe intoxication. When they can't make a safety plan and they absolutely refuse to participate in that in any way, I think that's another red flag. This is similar, another virtual hope box. There's an app for it. You can look it up. You can have people download it. There are a few apps like this, but most of them are, I think the safety plan has an app, the virtual hope box has an app, and I would encourage you to take a look at these. We talked about this, what would be the appropriate level of care, and talking to the caller about, here's what I think we need to do and why. And I think transparency is really critical. I think that reduces trauma. It increases the likelihood the person will go along with it. And that's what you want. Is we do this when it's a medical issue. We should do the same when it's a psychological issue. This is my last slide, just a little bit thinking about, this is a population that is at higher risk. People often don't go to their appointments, and I think our job is really to educate people about what to expect, why care works, what treatment looks like, and to offer that hope. So here's some resources, some of the things I talked about today. If there are things I mentioned, I saw a bunch of things coming up in the chat, so if I didn't mention them or somebody grabs them, I think that would be great. Or this is my contact information if anybody wants to reach out to me afterwards or has any questions. And I just want to thank you for spending your night with me.
Thank you, Julie. I mean, I found that a fascinating presentation and very informative and very eloquently put over. Thank you so very much for that. I think everybody here has really appreciated the time that you've given to us. We really do. Does anybody have any questions in the last couple of minutes that we may have available? Nobody has any questions? Suzanne?
I just wanted to add one thing. I studied with Edwin Schneidman, professor of thanatology at UCLA, decades ago before he died. And he really impressed upon our class. It stuck with me my whole career, is you do whatever you can to save the person's life. You say whatever you need to, you live for, he used to say, you live for that person. You borrow who they are and you speak for them. And this was back in the mid or late 1980s, early 1990s, but he was so brilliant in terms of the emotional aspect, how to connect emotionally with the person. So, but thank you for your presentation. It was wonderful, really useful.
Yeah, he's got great also theoretical thinking about sort of the psychological pain that somebody's in when they're thinking about suicide. He was really one of the first to articulate that.
Thank you, Sandra. Do you have anything that you'd just like to add, Sandra?
Sorry, did you You wanted me to say something?
I was just wondering if you had anything you wanted to
No,
add.
no, I'm just delighted that folks are here and found this conversation helpful. And we hope to continue bringing topics of interest to you. So if there are specific questions you have, specific topics you would like covered, I would love to have folks that are practicing in Israel also be part of this conversation. So if you can think of anyone that we should be reaching out to, so please don't hesitate, and I'll try to do what I can to help Susan to line up speakers as we keep going.
Thank you very, very much, Sandra. Thank you for your time. And Julie, thank you again. Thank you. It's really been very informative. I'm sure that we've all learnt a lot tonight. And really, I can't thank you enough for giving your time over to us this evening. If anybody does have any questions, just forward them and we'll get them answered. If anybody has any ideas about subjects that they would very much like to hear about, then let me know, and we can approach Sandra. And we've got some other ideas that we've got going forward as well. For the next 2 Sundays after this, we have some training coming up as well. So watch this space. And I thank you all for your time tonight. I'm now going to end the meeting because I have to do the QR codes for everybody who's online. Otherwise, you're not going to get them in time. So thank you again. And everybody keep safe and keep well, and we'll watch this space. Thank you.
Good night. Thank you.
Thank you so
Bye-bye.
much.
Thank you, everyone. It's good to see you all.
To see everyone. Take care.
Thank you.